This is a video, and this is a 33-year-old woman who is an alcoholic and presented with pretty classic symptoms of acute pancreatitis. Because she was young, her vital signs weren't that bad, a little hypertensive, maybe a little tachycardic for a 33-year-old, but otherwise doing okay. White count 13K, lipase over 1,000, LFT is normal, BUN only 24. And the initial CT scan was just hypoattenuation of the pancreas and signs of acute pancreatitis. 7 days later, the patient started to develop low-grade fever and leukocytosis, and there was some concern. And a repeat CT scan showed progression of the disease, and we're going to go to that CT scan now. So anyhow, so this, you'll see in the on the CT scan that this is a extensive collection here, you know, with a large collection in the lesser sac, a proximal collection, and then the collection extending down to a channel into the left colic gutter, and that is at day 10. We tried to ride this patient's symptoms out because she was persistently low-grade fever and leukocytosis, often the case when you have this much inflammation and necrosis in the abdominal cavity. Let's go on. So now here at day 30, we have a much more controlled collection. It's still extensive, heading down into the left colic gutter, but if you look at that proximal part of the collection, it's much more manageable and things are walled off. Let's go on. So here, you know, we've already placed the Axios, and a few days later, we are trying to see, we see that this the lambs is completely occluded with this coagulation necrosis, and using a snare, as was pointed out by Juha, it's just not very effective. Now here we decided to take out the EndoRotor, and you can see how effective it is against the you know, coagulation necrosis, the pancreatic necrosis, and we'll see later the fat necrosis. So we're clearing the proximal cavity here. Then we get down a little bit further into the cavity. We can continue with the EndoRotor. And, you know, we see that there's a little bit of pus down in further. So after we clear that proximal cavity pretty well, we decide to go ahead and put some stents in. And you can see these stents are extending down into the pelvis. And that is really to maintain our access and to prevent the pelvis from becoming a walled off section all to itself, okay? We could go on. All right, so then we come back and we leave those stents in, and we can go ahead. And on the video, you'll see that we're going to leave those stents in, and we're going to kind of go down along the stents, with the stents kind of providing us with a roadmap of how we're going to get down into the pelvis. And we're kind of chewing up both, you know, pancreatic necrosis as well as fat necrosis, and we make our way down into that colic gutter, and now we're seeing our access into the pelvis. And we stop there, and we bring that patient back after we put 3 stents in to maintain our access to the cavity. Go ahead. And here you can see the EndoRotor down next to the pelvis. Go ahead. So now we've kind of entered the pelvis, and in the pelvis there's almost exclusively fat necrosis, and the fat necrosis, it tends to be pretty soft, and the EndoRotor has a really is quite effective in this kind of necrosis. So we're just kind of clearing that large pelvic cavity. We do it almost all in a single session where we're clearing out the pelvis cavity. And as we get down to the base of the pelvis, you see the final recesses of the pelvis are really not involved in necrosis at all. And so we come back, and now we're going to review with you in kind of a time-lapse fashion that the cavity is completely clear. And this video is just to highlight the extent of this cavity. And over the course of 3 sessions, we really have cleaned out that entire left paracolic gutter, which is relatively impressive. And it would be something that we could not have done with the other tools that we have available to us. And I would say that most of these cases should be done with a drain, a percutaneous drain in the pelvis. We were just pretty fortunate in being able to do this one with endoscopic technique alone. So now we're all the way down in the pelvis there. That's the final recess. As you see, it's nice and clean, really no necrosis at all. All that fat necrosis is gone. And we're just going to pull out here and show you how large this cavity is. It's kind of narrowed down over time. And we'll still leave a stent in here to prevent, here's the final CT scan, and you see that there's a stent in the pelvis still, but there's absolutely no collection and no inflammation. So that's the extent of that video. Thank you.